Good afternoon and welcome you all to this teleconferencing session. In this teleconferencing session, we shall focus on neonatal resuscitation. To take this session, we have Dr. Saluja, who is Senior Consultant, Department of Child Health, Gangaram Hospital. We have Mrs. Kathuria, who is Principal and Professor, Thapar College of Nursing, Moga. We shall have 3 sessions. In first session, we will talk about initial steps of resuscitation. In the next session, we will talk about bag and mask respiration, and also we will talk about chest compression. And if the time permits, we shall also talk about KMC, that is Kangaroo Mother Care. I shall request all the regional centers to send us the attendance of the students and any clarifications they would like to seek from us. I will start the session. I will request Dr. Satish Saluja to start resuscitation and overview of the resuscitation.
Good afternoon, everybody. The first thing we want to know about is that what is resuscitation, or why do newborn babies need resuscitation? Those babies who are not able to initiate their breathing after birth because of various reasons are the ones who require resuscitation. Almost 90% of the babies do not require much assistance. It's only less than 10% would require either some assistance in form of initial steps, and about less than 2% will require bag and mask ventilation, and less than 1% would require chest compressions and medications. The most important thing before we proceed for resuscitation is to anticipate those pregnancies who at the time of delivery are likely to have babies who may have problems in transition. All the high-risk pregnancies like hypertension, anemia, diabetes, or any other medical disorder in the mother, or if the mother goes into premature labor, are the ones who are likely to get into problems. But we must also remember that 50% of the times need for resuscitation may come unexpected. So that is why it is very important that we have to be prepared for all deliveries so that we do not unduly delay the process of resuscitation, which means that we should be skilled in all steps of resuscitation. We should have all the equipment ready and in working order available for resuscitation, and most importantly, in today's time, we should have a resuscitation corner. All delivery areas wherever newborn babies are being born should have a resuscitation corner, or what we also commonly call as newborn corner. It should have a overhead radiant warmer, and in remote areas where radiant warmers are not available, we should try to have a 200-watt bulb overlying the baby or the area where we are going to conduct the resuscitation, so that we are able to provide warmth to these babies. We must also realize that resuscitation is a continuous process. It's a continuous, can I have the slide please? It's a continuous process of evaluation, decision making, action taking, which again is followed by further evaluations. Let's take an example. If a baby doesn't breathe after birth, that is our evaluation that the baby is not breathing. What is our decision? Our decision is that we have to make this child breathe. And what action needs to be taken? Action, either we physically stimulate the child to breathe, or we provide positive pressure ventilation with a bag and mask. So that is the action taken. And once the action has been taken, then we further evaluate whether by taking this action we met the desired result or not, which is whether the baby started breathing or not. Now we come to that, how do we go about resuscitation? I'll just take you through the various equipments which are required at the time of resuscitation. If you go through the list which is on your screens, we should have a radiant warmer, gloves to maintain hygiene, bulb syringe or suction catheters, stethoscope to count the heart rate, a shoulder roll which we'll talk about, blanket or towel, a bag and mask, some source of oxygen. And we're not talking about endotracheal intubation, so maybe in certain remote areas where these facilities are not available, but otherwise we should have a laryngoscope, suction catheters, endotracheal tubes, so on and so forth. Now, the whole concept of resuscitation has been divided into, I would say, three components. As we talk in terms of resuscitation, we talk about A, B, and C. A is for the airway, B is for the breathing, and C is for the circulation. So we will be talking about not all these three components, but only two components, which is A and B. We must remember that all these individual components should be completed within 30 seconds. That means when we are talking in terms of resuscitating a newborn baby, we are talking in terms of doing this process in about 1.5 to 2 minutes. We also know that newborn babies are born through a wet environment. They are wet because they are coming out of the uterus, which is full of amniotic fluid, and they tend to lose heat. And that is why these ABCs of resuscitations have been increased to TABC. We add T for temperature maintenance before A. So we'll come to these components when we talk in detail about resuscitation. And the last step is giving medications to the baby, which is sometimes referred to as the D part of resuscitation. So that is how it becomes T for temperature, A for airway, B for breathing, C for circulation, and D for drugs or medications. Now, before we proceed further to various steps of resuscitation, let me take you through how do we go about performing these steps. If you were to have the slide, please. At birth, we ask certain questions from the baby, from the obstetrician and ourselves, and decide about whether this baby is well or not. If the baby is well, we proceed towards a care which is called routine care. I'll talk about these questions little more in details when I talk about initial steps. But those babies who are not well at birth are taken for initial steps. We provide them warmth, do suction, positioning, maintain their airway, see that whether they are breathing or not. If not, provide them tactile stimulation. If they improve, check on their further assessments, check on their heart rate and color. If they become better, we take them for supportive care in the nursery. But if a child doesn't breathe, during these 30 seconds of initial steps, we provide these babies bag and mask ventilation.
Dr. Saluja, before we go on to these, I would like to request you to tell them what are the preparations needed. Though you mentioned something about newborn corner and equipments and all, so I would request you to show them these equipments which you have just listed on the slide, so that they can be aware about what are those equipments and what preparations are needed before starting any resuscitation.
Yeah, most of the times we don't need too much of equipment. We need some area where the newborn baby can be resuscitated. We need a source of heat or to provide warmth, which is a radiant warmer, or a 200-watt bulb, as I had said earlier. And then for most of the babies, we need very little equipment. I'll just show you this. We need dried, sterile sheets, and make sure that these sheets are washed, dried, and they are pre-warmed. So it's a good idea that when you are getting ready for resuscitation, you place these dry sheets under the heat source or under the warmer, so that they also become warm. If you were to dry the baby with a cold sheet, then you have chances of making this baby cold. Then you need certain suction catheters. If the baby has secretions in the mouth, you may need an equipment like this, which is a suction catheter with a Dealey strap, or you could have an ordinary suction catheter like this, which could be connected to a suction machine, which could be used to suction any secretions which are in the mouth of the baby. You need a tubing in case this baby requires oxygen supplementation. You need a bag which is required to give positive pressure ventilation in case the baby doesn't breathe, and along with these you need certain masks. Like this is a mask which gets attached to this bag, And with the help of this, we can give positive pressure ventilation to this baby. So we'll talk about this and more in detail. But other than that, in large majority of babies, we do not need much equipment. So you need an area where newborn babies can be resuscitated. You need a heat source, and you need very little equipment to resuscitate large majority of babies. We are not talking about endotracheal intubation, chest compressions or medications. So if you have this much of equipment, you are able to resuscitate 95% of the babies. Now in the next step, let's talk about how do we go about it, which we talk about as the initial steps of resuscitations, which are required virtually for most of the babies.
Before you go on to details of demonstration of initial steps, I would request Mrs. Kathuria to say something about initial steps. What are the initial steps which are to be followed?
Thank you, Dr. Kaul. The most important thing, as we know about the care of the newborn babies and in providing them resuscitation, is preventing the heat loss in the babies. As we all understand that heat is a very important component. Children are unable to maintain heat, especially when they come out of their mother's warm womb, and thus it is important to prevent the heat loss. And we will be soon demonstrating to you the steps of how the two pre-warmed towels are kept there, and the babies are immediately dried, the heat loss is prevented, and we will talk more about thermoregulation at a later point. And the first and the most important step is prevention of heat loss. And the second step, now for those babies who require resuscitation, is how to position the baby. The hyperextension of the neck or not extending the neck at all, that means we are not able to get into the respiratory tract and send the air or the oxygen through. So positioning of the baby is the second important step in resuscitation of the newborn babies. And now the third step. Suppose the baby has set some meconium, and if there are any kind of mucus plug or something which is bothering in the normal flow of oxygen or air into the baby's lungs, we want to do some suctioning. And just now Dr. Saluja has shown you certain catheters and pipes through which we are able to suck out the mucus or meconium into from the baby's respiratory system. So after these three steps, we then come to evaluation by seeing how is the baby breathing, whether there is a free flow of oxygen or not. That is the evaluation. And then we simultaneously keep on providing, we don't slap at the back, which has been a practice in the initial years, that putting the baby, holding the baby hard from the feet and upside down and slapping hard. No, no, no. The most important is to provide some tactile stimulation on the soles or on the back of the baby's body. Thus, and then to ensure that there is free flow of oxygen. So these are the 6 steps. Just to review: prevention of heat loss, positioning of the baby, suctioning of the baby, evaluation, and then tactile stimulation and seeing that there is free flow of air or oxygen into the baby's respiratory system. Thank you.
Dr. Saluja, I believe you have already talked about the 4 questions which they need to ask. I would request you to repeat those 4 questions. Based on that, they would decide about the step of resuscitation which has to be taken.
Yeah, Dr. Piti, before I do that, I'll just like to also tell you that the evaluation of a newborn baby during resuscitation should be done in a particular sequence. And this sequence is breathing, heart rate, and color. So whenever we evaluate our babies, we are going to evaluate first the breathing, then the heart rate, and then the color. How do we evaluate breathing? We can look at the baby and see whether the baby is crying and breathing well or not. How do we evaluate the heart rate? Heart rate is commonly evaluated by 2 methods. One, at the base of the umbilical cord, like if this is the baby and this is the umbilicus, you could hold the umbilical cord soon after birth between your thumb and the index finger, and you can feel the pulsations of the umbilical artery. If we were to count the pulsations over a period of 6 seconds, the number of pulsations in 6 seconds, if multiplied by 10, gives you the heart rate. Let's take an example. You count it for 6 seconds and the heart rate was 10. That means you multiply by 10, the heart rate is 100 beats per minute. If you count 12 in 6 seconds, that means the heart rate is 120. And the third part I told you in evaluation is the color. We all know that newborn babies may have slight peripheral cyanosis, that is bluish discoloration of the hands and feet, which is normal. To say that a newborn baby has cyanosis, the baby has to have central cyanosis, which means the tongue, the mucosa, lips and the central part of the body is blue. So we have to remember that we have to do 3 evaluations: the breathing of the newborn baby, the heart rate and the color. Now we come to the actual resuscitation at birth. At the time of birth, we ask ourselves 4 questions. The first question, whether the baby is born at term or not. We know whether the baby is full term or is preterm. So what we ask ourselves, is the baby born at term? That means yes or no. That means baby is born at term or is born premature. The second question we ask ourselves is the liquor clear of meconium? Which means whether the baby has passed meconium in the uterus or not. So whether the amniotic fluid is clear of meconium or not gets answered from this second question. The third question is the baby crying or breathing? Because crying and breathing is almost similar. So if the baby is crying and breathing, that is the third thing we want to know. And the fourth is the muscle tone good? We all know that healthy term babies will have normal flex tone. They keep their hands and feet together towards their abdomen. So if they have a good muscle tone, that is the fourth question we want to know. Just to repeat, is the baby born at term? Is the liquor clear of meconium? Is the baby crying or breathing? Is the muscle tone good? If answers to all these 4 questions is yes, which means baby is born at full term, the liquor is clear, baby is crying well, baby has a good muscle tone, then this is a healthy normal baby. And this baby goes for what we call as routine care. Just like to spend a couple of minutes here, that all those healthy babies who are born at term, are crying, have a good muscle tone and whose liquor is clear, there you need not take these babies under the warmer towards the resuscitation corner. What you can do is, you can take this healthy baby, I'll just demonstrate to you, and this routine care, like most often you would have the newborn baby in your hands, the obstetrician will have the newborn baby like this in the hands. Once you receive the baby, somebody clamps the cord, cuts the cord, and this baby is placed prone over the mother's abdomen and chest. Like mother is lying like this, we deliver the baby and place this baby prone with head turned to one side, right? And this we can abduct the hands and place it over the mother's abdomen like this so that the baby doesn't fall. And this is a sheet in which we receive the baby and turn the head to one side so that the nose and the mouth is not blocked. So this routine care is being performed on the mother's abdomen and chest for healthy babies. Then after we have done this, so what are we doing by placing the baby over mother's abdomen and chest? We are providing warmth. We are providing warmth by virtue of keeping this baby in skin-to-skin contact with the mother. That is what the kangaroo mother care is all about. So the same concept is being brought in at the time of resuscitation. So we place the baby in skin-to-skin contact, turn the baby to one side, and if we see some secretions over the baby's mouth, we can clean those secretions with this clean piece of cloth. And then we dry this baby, remembering that scalp makes a very important part of the surface area. We dry the baby's scalp, the neck, the back, axilla, both the arms, the legs, groins, and also the anterior aspect of the baby's abdomen and the chest, and also the mother where the baby is lying now. After we have done this, we throw away this sheet which has become wet now, take another sheet and then wrap this baby, cover the baby's head, and then this baby is now ready for breastfeeding. And we all know early initiation of breastfeeding saves most of the babies from morbidity as well as mortality. So this routine care is being performed on all the healthy babies who are born at term, who cry well at birth, whose liquor has been clear, there is no meconium in the liquor, and the muscle tone is good. So routine care need not be performed under a warmer. We just need to place this baby in skin to skin contact with the mother, which provides warmth, and that's it. And the baby is ready for breastfeeding. That's the beauty of this routine care being provided on the mother's abdomen.
So Dr. Saluja, you mean all the babies do not require resuscitation? These
Yeah.
babies now who are born normal, as they meet all these 4 criteria, these are the babies who would not be requiring any resuscitation as such.
Absolutely. So they just need to be dried and kept with the mother, and that is it. And that is what, when I said that 90% babies will need this. You have very few preterm babies who require resuscitation. Now when we ask ourselves the same 4 questions in certain situations where the baby is born premature, that means baby is not born at term, or if the liquor is meconium stained, or the baby doesn't cry at birth, or baby is born limp, the muscle tone is not good. That means answer to those 4 questions which we asked, if answer to any of those 4 questions is no. Can I have the slide please? These are the 4 questions we already discussed. Gestation, meconium, crying or breathing, and a good muscle tone. If answers to any of these 4 questions is no, then this baby goes for the steps of resuscitations which are called initial steps. That means healthy babies, no active resuscitation, routine care on mother's abdomen. Any baby who shows any sign of not being well goes for initial steps, which we are going to talk about now.
Yes.
Right? Now, we again try to go back to our old principles. TABC. T for temperature, A for airway, B for breathing, and that's how we'll talk about. What is the first step? T. Now, during initial steps, what do we do to provide T to these babies? We have this baby born with us. Once we are being prepared for resuscitation well before delivery, at least 20 to 30 minutes before delivery, the warmer where we are going to do the resuscitation should have been kept on, so that the whole environment beneath the warmer is become warm. And after delivery, we are going to place this baby under the warmer. Imagine there is a warmer here, and this baby is kept under the warmer. So what we have done? We have done the first step of resuscitation, that is providing warmth. By placing this baby under the warmer, we are providing warmth to this baby. That means we are taking care of T component of resuscitation. And then comes the next step, which is A. Now, let me tell you this, the T part of resuscitation has 2 components: placing the baby under a heat source and drying the baby. But we are deliberately not drying the baby right now, because drying is a stimulus for the baby. And by stimulating the baby before we have cleared the airway, we may stimulate the baby in such a way that if there were secretions like meconium or other things in the mouth, they may go into the trachea. So before we dry the baby, we will position the baby. Now, what is the position of the baby during resuscitation, which should be maintained? Just remember that slight extension of the neck. Slight extension, neither flexion nor hyperextension. Let me show it in this way. Neither hyperextension nor flexion, but slight extension of the neck, which can be maintained by the use of what? This is a roll of sheet, which is about 3/4 of an inch or a 1 inch. You can have, like, this is a sheet, and this can be transformed into a roll, which we now call it as shoulder roll. This roll, if placed under the baby's shoulder, we have made the roll and kept it beneath the baby's shoulders, and that achieves a position which is slight extension of the neck. It's not getting flexed, it is not getting hyperextended. So by keeping this roll beneath the shoulders, we are slightly extending the neck, which is the ideal position for this baby during resuscitation. Not only during initial steps, but also during bag and mask ventilation, also for endotracheal intubation or any procedure which is to be performed. So remember this, we have positioned this baby by slightly extending the neck. Now what have we achieved by doing this? By doing this, we have aligned the oral airway and the tracheal airway in such a way that they are clear. That is mechanical clearance of the airway. That means we have done the first part of A, which is airway. Is it clear? However, if you were to flex, the airway gets angulated. If you were to extend, hyperextend, the airway gets angulated and the air cannot freely flow from the mouth towards trachea. So by keeping in this, we have cleared the airway manually or mechanically. Let's talk about the second part of A, which is clearing the airway of any secretions. Here we have to decide whether the secretions or the fluid or the amniotic fluid is clear of meconium or not. Let us presume that the liquor is not meconium stained. If it is not meconium stained and if we can see the secretions in the mouth, then we need to suck the secretions from the mouth and the nose. We all read alphabets, A, B, C, D. M comes before N, right? M-N-O-P. So that is why the mouth needs to be sucked first and then the nose. You can use this suction device or you can use a suction catheter which is attached to a central source of a suction machine. Just remember that the negative pressure on the suction machine should not be more than 100 millimeters of mercury. Or you could use this. You can just suck the mouth and then the nose. Not that you suck the nose first and then the mouth, because if you were to suck the nose first, whatever secretions are lying in the mouth can be inhaled into the trachea and the lungs. Because whenever you do suctioning, you are stimulating the child to breathe. So it's very important that you do suction of the mouth and then do the nose when the mouth is clear. Also remember that you should not do very vigorous suctioning into the mouth so that you are touching the posterior pharyngeal wall. By doing that, you can cause bradycardia in the baby. So it's a good idea to peep over the mouth and see whatever secretions are there you can pick up directly. Or what else can be done is, you could, I don't know whether it's you could turn the head of the baby to one side so that whatever secretions are there, instead of collecting at the back of the throat, they are collected over the cheek. And then you can perform suctioning over the cheek rather than from the throat, because we know that the vagal nerve endings, they are at the back of the throat and not over the cheek, and you will not induce bradycardia there. Is it right?
Dr. Saluja, I
Yeah.
have seen people taking a piece of gauze and then putting inside the mouth of the child and sucking and cleaning like this.
Yeah,
Is
then
it all right
then we are being
to do that?
cruel to these babies. Then we are blocking the airway. If there are thick tenacious secretions, we may further push them down. So it's not a good idea, but if you can see some secretions outside, then you can just wipe them like this. Don't try to
Put
push
the
the
fingers.
finger into the mouth of the baby and try to clear the airway like that.
It has been a very common practice observed during community practice,
Yeah, I
especially
think-
with the DICE, TB, trained birth attendants and all that.
So you see, if suction device is not available, then you can gently wipe the mouth, and if you can see some secretions, don't try to push your finger
fingers
into the
inside.
mouth of the baby.
that
So what
should
have we
never be
done? We have done two parts of A. That means we slightly extended the neck, we cleared the airway, and then we cleared the airway, mouth first and then nose. But here comes the question that if this liquor was meconium stained, then what do we do? If the liquor is meconium stained, then we have to decide whether this baby is a vigorous baby or a non-vigorous baby. Let us know what is a vigorous baby. Any baby whose breathing effort is very good, whose heart rate is more than 100, that means when I count the heart rate at the umbilical stem, it is 10 in 6 seconds or more than 10 in 6 seconds, and the third part is that the muscle tone is good. So good, strong breathing efforts, heart rate more than 100, good muscle tone are indicating that this baby is a vigorous baby. Earlier we used to talk about thin meconium, thick meconium, those situations have gone. If the baby who is born through meconium stained amniotic fluid and is vigorous, we do not have to do anything special. But if baby is born depressed or is non-vigorous, which means baby doesn't breathe well, is either apneic or is gasping, baby's heart rate is less than 100, or muscle tone is not good, baby is hypertonic or limp, then we need to do endotracheal suctioning. I think endotracheal suctioning we are not talking here. So that is the second. So we have taken care of A. We have positioned the baby, we have cleared the airway, whether this is meconium stained or not. Then what do we do? After that, we come back to the second part of T, that means drying the baby. Now that we have cleared the airway, now we dry this baby. Again, making sure that we have dried the scalp, we have dried the neck, we have dried the arms and the axilla. Axilla are very often forgotten. Axilla on both the sides, the abdomen, the groins, legs on both the sides. Similarly here, turn the baby to one side, dry the back portion, and after we have dried with this sheet has become wet, we throw it and take another clean pre-warmed sheet, and then if there is a need to wrap this baby, we wrap the baby. But surely if the baby is under the radiant warmer, we can leave the baby like this.
You can also say that endotracheal intubation is only performed if there is this skilled person is present at the time of birth of the baby and is specially trained, then at that time they can...
Surely. When we talk in terms of endotracheal intubation, we are talking only to those situations where we have skilled personnel to perform endotracheal intubations. But then we are trying to make you aware that if a baby is vigorous with meconium stained amniotic fluid, we don't need endotracheal suctioning. That's the purpose. So we have taken care of T, we have taken care of A. And by drying this, the second part of temperature maintenance is also taken. Now what do we do after this? While we were drying this baby, the position of this baby would have changed. And that means we reposition the baby. We make sure that the shoulder roll we kept beneath the shoulders is again properly placed and the baby lies in slightly extended
what is this
neck.
position called as?
This 3D position.
No, we neither hyperextend nor hypoextend the baby's position. This position is
This position is also called a sniffing position. Commonly when we sniff at the rose, then we slightly extend our neck. So this commonly is referred to as sniffing position, but I think as scientific personnel we need to know that the neck needs to be kept in slightly extended position. After we have done this, after we have cleared the airway, we have dried the airway and then repositioned this baby, then comes the next step. Then what do we do? After this we make an assessment whether this baby is breathing or not. I told you evaluation or assessment is in this sequence: breathing, heart rate and color. Then we make our first assessment, which is breathing. If this baby is breathing, fine. Let us presume if this baby is not breathing. That is our evaluation. What is the decision? Decision is we have to do something to make this baby breathe, and the action to be taken is tactile stimulation. Now as Dr. Kuturia mentioned earlier on, it was an old practice that you hang the babies upside down, you keep slapping those babies. Absolute no to that form of tactile stimulation. Tactile stimulation has to be gentle and just couple of times. How do we do that? We could just give couple of flicks. We could just give couple of flicks like this over the sole of the baby, or couple of taps like this over the sole of the babies, twice only. And that is, can I have a close-up for this? I think they can see the... yeah, if you do just give couple of flicks, this is good enough, or couple of taps like this over the sole. It's not that you keep doing, this is not done. Just twice or twice like this. Also remember that gently rubbing the back of the baby, is also another form of tactile stimulation. Very often this child will breathe, right? So what have we done? We have provided a physical stimulus for the child to breathe. And now if this child doesn't breathe, what do we do? If a child... Yeah?
If I have still seen many people doing like this,
Yeah, I didn't want to hang
and then do like that.
That is absolutely no. Please never do this. I didn't want to demonstrate that because
I
that
have
looks
also
very ugly.
seen them to do, flex the knees like that, thighs on the abdomen and then doing it.
Just remember only couple of stimulations like this. Forget about all other practices.
No, like this.
Nothing. No other practice. Whatever you may be doing, squeezing legs into the abdomen of the baby, slapping the baby very hard, these practices are not to be done. Now, if after couple of tactile stimulations, the baby is still not breathing, what do? We provide this baby bag and mask ventilation. So that becomes the first indication of providing bag and mask ventilation, which means after 30 seconds of initial steps and providing tactile stimulation, if the baby doesn't breathe, is still apneic, we provide positive pressure ventilation. Let us presume a scenario where after tactile stimulation, the baby starts breathing. Then what do? We go to the next evaluation. And what is the next evaluation? Heart rate. Now remember this heart rate of 100. If the heart rate is more than 100, it's fine. But if the heart rate is less than 100, then this baby requires bag and mask ventilation. Which means after 30 seconds of initial steps, if the baby is breathing well, but the heart rate is less than 100, we provide them positive pressure ventilation. So this is a second indication of positive pressure ventilation. But if the baby is breathing, the heart rate is more than 100, what do? We go to the third evaluation. And the third evaluation is, I said, color of the child. We have to look for central cyanosis. If this baby has central cyanosis, then what do? We have to provide this baby free flow oxygen. Because he is breathing well, his heart rate is more than 100, but he has central cyanosis. That means this baby needs free flow oxygen. Now we will learn how to provide free flow oxygen to the baby. Just remember that don't give oxygen to a baby who is not breathing. Because if you are giving oxygen and the baby is not breathing, the oxygen is not going into the lungs and the baby doesn't get benefited. For providing oxygen, we need an oxygen source, which could be an oxygen cylinder, a tubing through which the oxygen flows, and here is the baby. The flow rate on the oxygen should be 5 to 6 liters per minute. This could be easily given with a cupped hand. You can hold, can I have the closer please? The closer. Yeah, you can make a cup and by holding this tubing in your hand like this and place it over the baby's mouth and the nose like this. So if you were to make a cup like this and place it over the baby's mouth and nose, you are giving this baby free flow oxygen. And the flow should be 5 to 6 liters. Just remember that you should not make a very tight seal. Just let it loosely be there. And the baby breathes in oxygen, and then after giving oxygen for 30 seconds, you assess the baby again, whether this baby's central cyanosis has disappeared or not. If the central cyanosis disappears, then you gradually withdraw this oxygen. The other way of giving oxygen is, you could use this mask and attach the oxygen source to this mask and then loosely keep this mask over the baby's mouth and nose, and this also gives free flow oxygen. And once the baby becomes pink, then you gradually withdraw this oxygen and see if the baby continues to be pink. But if after giving free flow oxygen for 30 seconds, baby continues to have central cyanosis, that is the third indication of bag and mask ventilation. Which means that if after initial steps, baby is apneic or gasping, which means baby is not breathing, or if the baby is breathing but the heart rate is less than 100, or if the baby is breathing, the heart rate is more than 100, and after you have given free flow oxygen for 30 seconds, baby still has central cyanosis, we need to give this baby bag and mask ventilation. So these become 3 indications of positive pressure ventilation with the help of bag and mask. After this baby has recovered, and what are the signs of recovery? Baby is breathing, baby's heart rate is more than 100, baby has become pink, then this baby goes for a care which is called observational care. Observational care could be with the mother, or it could be in a special area where newborn babies can be monitored. So here I will stop with the initial steps, and if you have any questions, I'm sure they'll send you some questions. We can respond to that. And in the next
I
session,
request regional centers to send us the attendance of the students and if any queries are there in this demonstration. There are no questions? There are no students at the regional centers, we presume then? Okay, thank you Dr. Saluja and Mrs. Kothuria for taking nice presentation and nice demonstration by Dr. Saluja. I think students, if at all present at the regional centers, must be witnessing this demonstration, and they will get benefited with this such a nice demonstration, and they will also remember how do they decide about the ventilation, the resuscitating the baby. And in the next session we will talk about bag and mask ventilation and chest compressions, and then if the time permits we'll go on to the kangaroo mother care. Thank you very much for this session.
कोलकाता, कलिकाता या कलकत्ता, आप इसे कुछ भी नाम दें, इसके नाम मात्र से एक ऐसे नगर की छवि जहन में उभरती है जिसका एक समृद्ध इतिहास है। 3 शताब्दी पहले कोलकाता एक छोटा सा गांव होता था, जो इस कालावधि में भारत के सबसे बड़े शहरों में से एक बन गया है। कोलकाता का पुराना नाम कलिकाता था, जो उन 3 गांवों में से एक था जिन्हें जॉब चारनाक ने ईस्ट इंडिया कंपनी के कारोबार के लिए चुना था।